Twin pregnancy. Twin pregnancy can be of two types, dizygotic and monozygotic twins. Dizygotic twins occur when fertilization of two ova occurs by two different sperms. Hence, two zygotes are formed and both get implanted. This is the most common type. Around 70% cases are dizygotic twins. In monozygotic twins, fertilization of one ova occurs with one sperm. One zygote is formed and it undergoes division. This is the case is in around 30% of twin pregnancies. Dizygotic twins are fraternal twins, whereas monozygotic are identical twins. Now in dizygotic twins, the most common type is dichorionic diamniotic. Each baby will have one amnion layer and outer chorion layer. In monozygotic twins, the type depends upon the time of division. The chorion forming cells commit around day 4 and the amnion forming cells commit at around day 8. So, if cell division occurs at 72 hours, that is the morula stage, the type will be dichorionic diamniotic. If the division occurs around 4 to 8 days, that is the blastocyst stage, the type will be monochorionic diamniotic. If division is around 8 to 12 days, the type will be monochorionic monoamniotic. If division is around more than 12 days, when the formation of embryonic disc occurs, the type will be conjoined twins, and conjoined twins are the type of monoamniotic twins. And the most common type of monozygotic twins are monochorionic diamniotic. Now in the images you can see the four types. The first image is of dichorionic diamniotic. There are four layers in the dividing membrane. In the second type it is monochorionic diamniotic. There are two layers in dividing membrane. The third type is monochorionic monoamniotic. There is no dividing membrane between the babies. In this case, the cord can get entangled and can form a knot, leading to intrauterine death. In the fourth type, that is the conjoined type, there is no dividing membrane. The most common type of conjoined twin is known as parapagus, in which the fetuses are joined laterally, that is, joined by lower abdomen and pelvis. The second most common type is thoracopagus, in which the fetuses are joined from thorax to umbilicus. The least common type is rachypagus, joined by vertebral column, and craniopagus, joined by cranium. Now, there is no entity like dichorionic diamniotic. In monochorionic twins, the fetuses share vascular anastomosis. In dichorionic twins, there is no vascular connections. Now, regarding the placenta, in the first image, there is a dividing membrane present and it is thick. This signifies dichorionic diamniotic type. The dividing membrane signifies diamniotic type and the thickness signifies dichorionic diamniotic. There will be no vascular connections present. Now, most commonly, they have single placenta and only 3% of them have two placenta. This is regarding the twin pregnancy. And in single placenta, there will be presence of anastomosis. In the second image, there is a presence of dividing membrane, hence it is diamniotic. There are thin vascular connections present, hence it is monochorionic. In the third image, there is no dividing membrane and cord entanglement in C, so it is monochorionic monoamniotic. Please note that if there are more than two membrane layers in placenta image, it will be dichorionic diamniotic. Now, when will we suspect twin pregnancy? So, for clinical suspicion of twin pregnancy, we have to do per abdomen examination, in which fundal height will be more than the period of gestation, multiple parts can be palpated, and two fetal heart rate will be auscultated, and there will be difference of 10 beats per minute between them. Ultrasound, most important is the first trimester ultrasound. Ultrasound confirms multifetal pregnancy. Now, there is a term called vanishing twin, in which there is spontaneous reduction of one twin and it is seen in early pregnancy. On ultrasound, we can also do estimation of gestational age to manage the complications, and this occurs due to discrepancy between the twins. We can do the assessment of chorionicity or amniocity. Also, we have to look for nuchal translucency. Increased nuchal translucency is a marker of Down syndrome. Down syndrome risk is more in dizygotic twins. The risk is twice than that of singleton pregnancy. In monozygotic twins, the risk is same as singleton pregnancy. Either both have the disease or don't have the disease. Increased nuchal translucency is also a marker of twin-to-twin transfusion syndrome, where the inter-twin difference in nuchal translucency is more than 0.6 mm. This marker indicates if there is likely development of twin-to-twin transfusion syndrome. Now, vanishing twin we have already discussed. It occurs in early pregnancy. Now the markers of dichorionicity on ultrasound. Seeing two different placenta signifies dichorionic. Single placenta signifies dizygotic, as placenta can fuse later, or monochorionic. Opposite sex twins are always dichorionic. Same sex twins can be dichorionic or monochorionic. Twin peak sign, also known as lambda sign, is seen around 10 to 14 weeks. This sign occurs because chorion is entering the dividing membrane. In monochorionic, it does not enter the dividing membrane. Most commonly, T sign is seen, or inverted T sign. On ultrasound, we can see the number of layers in dividing membrane. If it is more than 2, it is dichorionic. Most commonly, there are 4 layers seen, 2 chorionic and 2 amnion layers. The thickness of dividing membrane will be more than equal to 2 mm. Now in the images we can see in monochorionic twin there is T sign, in dichorionic twin there is lambda sign. Remember this: monochorionic T sign, dichorionic twin lambda sign. Now monochorionic twin pregnancy have higher risk of complication, and twin pregnancy is high risk for both mother and fetus. Now we will discuss the maternal complication. These complications are dependent on number of fetus. First complication is greater hemodynamic changes are seen in the mother, 20% more than singleton pregnancy, and the anemia risk is also increased. There is complication of hyperemesis gravidarum. This occurs due to increased beta HCG. In this, excessive vomiting is seen, due to which the mother can be required to be hospitalized or require some medication. There is risk of preeclampsia or gestational hypertension. There is risk of gestational diabetes mellitus due to increased human placental lactogen that causes insulin resistance. There is risk of intrahepatic cholestasis due to increased estrogen. There is risk of placenta previa, acute fatty liver of pregnancy, preterm labor or premature rupture of membrane due to overdistension of uterus or postpartum hemorrhage. Now the fetal complications. All fetal complications are higher in twin pregnancy as compared to singleton, except macrosomia and post-term labor. Most common fetal complication is prematurity, occurs in preterm labor. Number of fetus determine this complication. Now regarding some specific complications of monochorionic twins. These complications occur because of vascular connections. First is twin-to-twin transfusion syndrome. This is seen more commonly with monochorionic diamniotic twins. The cause is connection between deep artery of one twin and deep vein of other twin. Monoamniotic twins show superficial artery-to-artery anastomosis. Now in this complication, deep artery of one twin and deep vein of other twin are connected. So donor twin to recipient twin, the transfer occurs. In donor twin, there will be decreased blood volume causing decreased renal blood flow that can lead to increased peripheral vascular resistance causing heart failure. Decreased renal blood flow can also cause oliguria and can lead to oligohydramnios. In the recipient twin, there is increased blood volume causing increased renal blood flow leading to polyuria and then polyhydramnios. In the recipient twin, heart failure can occur due to volume overload. The diagnosis of this syndrome is on ultrasound, where we can see simultaneous polyhydramnios in one twin and oligohydramnios in the other twin. The treatment of this syndrome is laser ablation of vascular anastomosis. This is an intrauterine surgery and fetoscopic laser is used. There is one staging of this syndrome known as Quintero staging. In stage 1, one baby is polyhydramnios, other is oligohydramnios. Bladder of oligo baby is visible and Doppler is normal. In stage 2, poly plus oligohydramnios seen. Bladder of oligo will not be visible and Doppler will be normal. In stage 3, poly plus oligo seen. Bladder of oligo will not be visible and Doppler will also be abnormal. In stage 4, one or both babies develop hydrops fetalis, that is heart failure. In stage 5, one or both babies die. Another complication will be twin anemia polycythemia sequence. Here, one baby develops anemia and other baby develops polycythemia due to very small AV anastomosis. This will occur without amniotic fluid discordance. Diagnosis of anemia is by MCA peak systolic velocity more than 1.5 multiples of meridian. Polycythemia diagnosis is by middle cerebral artery peak systolic velocity less than 0.8 multiples of meridian. Another complication is twin reversed arterial perfusion TRAP. Here, artery to artery anastomosis between umbilical arteries of babies are seen. One baby receives retrograde arterial blood flow, causing a cardiac twin. Only the lower part of body develops. Next complication is selective IUGR. Only one baby will have IUGR, other baby will be normal. IUGR is estimated fetal weight less than 10th percentile. There will be growth discordance seen. Difference between intertwin weight will be more than 20 to 25% and the bigger twin will be taken as reference. Next is single fetal demise can occur. Here we will continue pregnancy with fetal monitoring. Congenital malformations are common in monochorionic twins, less common in dichorionic twins, and even less common in singleton pregnancy. Now regarding some specific complication of monoamniotic twins. There can be cord entanglement and high risk of fetal death beyond 34 weeks. Now the management of twin pregnancy. First is antenatal management. We have to do more frequent antenatal visits. We have to check for weight gain, fetal heart rate, fundal height. Urine should be estimated for protein, glucose. We must do evaluation for preterm labor or preeclampsia. Diet: additional 350 kilocalorie should be added from singleton pregnancy. Additional 60 milligram of iron additional to singleton and 0.5 milligram folic acid should be added additional to singleton. Bed rest should be advised 2 hours in day, 8 to 10 hours in night. Patient should avoid strenuous exercise. Patient should be screened for anemia, aneuploidy, gross congenital anomalies. Ultrasound should be done in first trimester and level 2 ultrasound should be done. More frequent ultrasound is advised to monitor growth every month in dichorionic and every 2 weeks in monochorionic. For fetal surveillance, we will do non-stress test, biophysical profile or Doppler. We should plan for mode of delivery. In case of IUGR, growth discordance, twin-to-twin transfusion syndrome and TRAP, we have to do Doppler. We can start aspirin on low dose. We can start at 12 weeks. The indications are in first pregnancy, previous history of preeclampsia, more than 40 years age of patient, and if BMI is more than 35. What are the indications for C-section in twin pregnancy? If the first twin is non-vertex, the most common combination in labor is first twin vertex, second twin vertex. Second most common combination is first twin vertex and second twin breech. Time of delivery in dichorionic twins is 38 week, in monochorionic 36 week, monoamniotic 34 week. Other indications are conjoined monoamniotic twins, discordant fetal growth, twin-to-twin transfusion syndrome, and twin interlocking. In this, first twin will be breech, second twin vertex. The preferred mode will be C-section. Twin interlocking is a term in which after coming head of first twin gets locked with the head of second twin. The obstetric indications of caesarean section are contracted pelvis, placenta previa, and fetal distress. What will be the intrapartum care? 2 obstetricians and 2 neonatologists should be present. Continuous fetal heart rate monitoring should be done. We should arrange blood and blood products as increased risk of PPH is there. We should secure IV access. Now, if the first twin is vertex, we should go for vaginal delivery when cervix is fully dilated, since head doesn't stuck in second breech twin. Second twin breech, we will do vaginal delivery. First twin vertex and second twin breech, we will do vaginal delivery. If second twin is in transverse lie, there is no mechanism of labor for transverse lie. The specific procedure that we can do is internal podalic version plus breech extraction will be done. The internal podalic version is done in OT under general anesthesia. In the diagram we can see internal podalic version plus breech extraction. Only indication of this procedure is if second twin is in transverse lie. Thank you.